Hi. Today we are going to learn on how to recognize critically ill children. Good day everyone. Today we are going to learn on how to recognize ill children. In this lecture, we are going to look at things that need to be considered when we are talking about pediatric emergency. How to assess pediatric patients. How to differentiate between respiratory distress and respiratory failure. And how to recognize and manage shock in children. First of all, children should not be considered small adults. Their physiological functions and needs are quite different from adults as shown in this slide. As you can see, obviously their sizes and body proportions are different. In babies their anterior fontanelle can still be open. Children have larger head in proportion to the body. Their necks are shorter. They have flat nose and their facial contours are not well developed. They rely a lot on the diaphragm to breathe. They have faster respiratory and heart rate. Their bones are softer. They have larger body surface area. And finally, their temperature control is immature, making them prone to get hypothermia. For breathing considerations, there are some important points that you need to remember when handling children. 1. Respiratory illnesses in babies and children are common and these can be life-threatening. 2. Cardiac arrests in babies and children are most frequently caused by hypoxia. 3. In evaluating the breathing, both the effort, i.e. how hard the child is working, and the efficacy, i.e. how effective they are in gaseous exchange, must be assessed. Finally, ineffective breathing leading to hypoxia or hypercapnia may cause agitation and decreased level of consciousness. Circulation considerations. Another important point that needs to be considered in pediatric patients is the blood volume. Total circulating blood volume per kilogram is greater than adult, but absolute blood volume is lower than adult. Therefore, what appears to be small amount of blood loss will add up quickly. As you can see in this picture, each bottle represents 500 milliliters. At the age of 6 to 10 months old, the circulating blood volume is around 500 milliliters. As compared to 12 to 13 years old, the circulating blood volume is 3 liters. If a 10-month-old baby loses 125 milliliters of blood, for example due to bleeding, that is already 25% of his or her circulating blood volume. But if a 12-year-old loses the same amount of 125 milliliters, that is only 4% of his circulating blood volume. Therefore, the younger they are, the more likely for them to develop shock rapidly. Fluid and electrolyte balance. Children require careful titration of fluid and electrolytes to maintain their hemodynamic stability. Additional factors that may affect fluid and electrolytes imbalance are: 1. Their larger body surface ratio. 2. Higher metabolic rates. 3. Higher susceptibility to dehydration, electrolyte loss. And 4. Hypothermia when ill. Fluid requirements and medications. It is important to remember that in children, fluid requirements and medication dosages must be calculated based upon the child's weight in kilograms, rather than the standard unit requirements or dosages used for adults. Therefore, a calculator and a drug reference book are mandatory in calculating medications for children to prevent any medication error. In the next few slides, we will go through the clinical assessment of a child. In order to recognize a sick baby or child, a thorough and structured pediatric assessment are required. This slide shows how an illness or precipitating condition affects children. If it is severe, the endpoint will be either respiratory or circulatory compromise. For respiratory, children can go into respiratory distress or respiratory failure, or they go into shock, which will then lead to cardiopulmonary failure. In the end, This will result in cardiac arrest or death. So how do we recognize a sick baby or child? As previously mentioned, a structured approach is required. Assessment of babies and children is sometimes difficult as the symptoms and signs of illness may not be as marked or as readily expressed as those in adult patients. The initial rapid assessment is to have a quick look at the patient. This should only take about 5 seconds. As we go accordingly, look at the appearance of the child, followed by the work of breathing and general inspection at the circulation, namely the skin color or presence of any bleeding. The next step is to do primary assessment. This is evaluation of the A, B, C, D, E. Now we will go through step by step of A, B, C, D, E, which represents airway, breathing, circulation, disability, and exposure. Remember that you should not proceed to the next step before treating or securing any abnormalities. For airway, we need to look, listen and feel. First look for movement of the chest and abdomen, followed by listening to the breath sound and air movement. Then feel for the movement of air at the nose and mouth. At the end of airway assessment, ask yourself, is the airway clear? Is it maintainable or not? If the airway is not maintainable, there are some maneuvers that you can do and some adjuncts that you can apply in order to secure the airway. For example, head tilt, chin lift and jaw thrust. You can do suctioning to remove any secretions. And lastly, you may insert the nasopharyngeal airway or oral airway. If the airway is not secured by simple maneuvers or adjuncts, an advanced airway is required. This includes bag valve mask ventilation. Then preparing for intubation or cricothyrotomy. If the problem is in upper airway, for example in the case of laryngomalacia, we can apply pressure to distend the airway using continuous positive airway pressure or CPAP. After we have secured the airway, the next step is to evaluate the breathing. First, count the respiratory rate. Next, look at the breathing effort. Then listen for presence of stridor, grunting, or wheezing, and auscultate the chest for breath sounds. Finally, apply pulse oximetry to look at the oxygen saturation. At the end of assessment, ask yourself, is the breathing pattern normal? Is the child in respiratory distress or failure? This is a table showing normal respiratory rate for different age group. In infant less than 1 year, tachypnea is defined as respiratory rate more than 50. In toddler 1 to 3-year-old, more than 40. In preschooler 1 to 5-year-old, more than 34. In school age 6 to 12-year-old, more than 30. And in adolescent 13 to 18-year-old, more than 16 breaths per minute. Fast respiratory rate is tachypnea. This may indicate the child is in respiratory distress. Slow respiratory rate is bradypnea, and this may indicate that the child is tiring out with impending respiratory failure. If the child doesn't breathe at all for more than 20 seconds associated with bradycardia, cyanosis or pallor, then it is called apnea. This is a sign of respiratory failure. Apart from respiratory rate, look for any signs of respiratory insufficiencies such as usage of accessory muscles. For example, nasal flaring, chest recessions, head bobbing, seesaw or paradoxical breathing. And ask yourself again, are there any signs of respiratory distress or failure? Next we need to assess for the breath sounds and decide whether it is adequate or equal bilaterally. We also have to listen for any additional abnormal breath sounds such as stridor. This may be due to upper airway obstruction, wheezing or ronchi. This may be due to lower airway obstruction, grunting and crepitations. These may be due to lung tissue disease. Next we go to circulation. In circulation, we have to assess the cardiovascular function. For example, we look at the skin color and feel for its temperature. Check the heart rate. Assess the rhythm. Measure the blood pressure. Feel the pulse volume. And check the capillary refill time. Next we should check the end organ perfusion by checking the mental status for brain perfusion and urine output for renal perfusion. At the end of your assessment, ask yourself again, is the patient's circulation is adequate, or the child is developing shock? Heart rate of a child varies according to age, activity and clinical condition. This table shows the definition of tachycardia for different age group. In infant less than 1 year, tachycardia is defined as heart rate more than 160 beats per minute. In children less than 2-year-old, more than 150. In a 2-year-old, more than 130. In a 4-year-old, more than 120. In a 6-year-old, more than 115. And in an 8-year-old and older, more than 110. Look at the cardiac monitor for heart rhythm. This slide shows normal pattern of heart rhythm. Blood pressure is an important parameter that needs to be checked in every critically ill child. If the blood pressure is low for age, they are at risk of going into the state of shock. This slide shows the formula to estimate the 5th and 50th centile for blood pressure in children. Pulses should be felt in the brachial and femoral in children less than 1-year-old, whereas radial and carotid pulses should be palpated in those greater than 1-year-old. Weak pulse is an emergency, a sign of shock, and may imply impending cardiac arrest. Measuring capillary refill time is important to ascertain whether the circulation is adequate for a patient. This is measured by pressing for 5 seconds on the skin, releasing, and counting how long it takes for the color to return. A normal capillary refill time is less than 2 seconds. If the patient is in shock, the capillary refill time will be prolonged more than 2 seconds. However, please be aware that in warm septic shock, the capillary refill time may still be normal. Pallor, mottled skin, cyanosis, and cold extremities are signs of inadequate peripheral circulation. Another way of assessing circulation is by looking at end organ function. Look at the mental status, which indicates the brain perfusion. The decreased level of consciousness, confusion or agitation may each be an indication of inadequate circulation to the brain. Severe compromise of brain circulation leads to pupillary dilatation and complete loss of consciousness. Reduced urine output or oliguria indicates inadequate circulation to the kidneys. Shock is defined as a state of cellular and tissue hypoxia due to inadequate oxygen delivery to meet the metabolic demand. This most commonly occurs when there is circulatory failure leading to reduced tissue perfusion. Shock is a clinical state where the heart is unable to catch up with the metabolic demands of the body. It can be divided into compensated and uncompensated. In compensated shock, the child has 1. Tachycardia, 2. Reduced pulse volume, 3. Prolonged capillary refill time more than 2 seconds. 4. Pylor. 5. Cyanosis, and as well as cold hands and feet. However, the body is able to compensate, so the blood pressure is still normal. In uncompensated shock, the child has all the signs of shock as mentioned. However, the compensatory mechanisms in the body fail to maintain the blood pressure, so the child has low blood pressure. But bear in mind this is a late sign, so do not wait for the blood pressure to drop before diagnosing shock in a child. Finally, take-home message for you. The physiological functions and needs of children are different from adults. Always have a structured assessment to make sure important things are not overlooked. The most common cause of cardiac arrest in children is respiratory failure. Hypotension is a late sign of shock. That concludes our session. Thank you for your attention and have a nice day.